So, good evening, everyone. Today, we're going to continue our series on toxicology. So, today's topic, before we start today's topic, I'll start with a small case scenario. So, a 27-year-old lady is brought to the mental department with complaints of altered mental status in the past few hours, and they're giving a history of some unknown medication ingestion a few hours back, but they're not exactly sure exactly what happened. So, she was on some medications that are not exactly sure which. And they're feeling that she might have overdosed on some pills. So, in this particular scenario, Arushi, so how would you like to proceed with in this particular scenario? Just a basic idea.
So, firstly, the vitals of the patient, I see whether the patient is stable or not,
Mm.
like the volume, the heart rate, and the blood pressure. A basic RBS I would like to do, and any known comorbidities of the patient, basic investigations I would like to send.
Okay, so very good. So initially, of course, we'll always start with the primary survey ABCD. That's always our initial focus. And in the history part, the most important thing that would be a medication list, so that will help uh, narrow our differential quite a bit, or a photo of the medication, photo of the cover, anything that might give you a clue about what exactly might have been ingested by the patient. And that is one thing. And others, as you said, vitally is going to be vitals are important. Whether airways patent or not is important. Pupils are going to be important. RBC in any alternative intubation, RBC is always going to be very important, as she said rightly. And this patient is going to be trached red. So this is going to be a priority diagnosis. That is pretty clear. This is not some patient that you are going to be keeping waiting in the queue under any circumstances. So today's topic is basically on tricyclic antidepressant toxicity. So TCAs are basically two groups. So you don't actually need to know the two groups because there's more pharmacology than toxicology. But just for completion's sake, I'm mentioning here there is tertiary amines and secondary amines. Tertiary amines include amitriptyline, doxepin, and your pramines, the clomipramine, imipramine, trimipramine, most of them. Secondary amines include your dacipramine and other drugs like nortriptyline and protriptyline. So at least be familiarized with the names of these medication so that when you read them someday you'll get an idea that okay, this is a tricyclic antidepressant. So there have multiple uses in psychiatry, and the basic thing about them is that the popularity is generally coming down in the previous 2 decades because compared to SSRIs, they are generally have more side effects and are thought to have be more toxic in overdose. Even though in recent times that might be changing again, but I'm not really the best person to talk about that. But in general, as TCS have fallen out of favor to SSRIs. But it's still important to understand the toxicity because the TCA toxicity it has a lot of similar features with a number of other toxicities that you may encounter during everyday practice. So you have to be aware of actually what the toxicity consists of. So the basic pathophysiology of sodium channel blockade, and which is basically the most toxic effect of tricyclic antidepressant overdose, is that it will cause slowing of the depolarization of your cardiac myocytes, and most importantly, it will slow down the phase zero of the depolarization, the upward slope here. So that is a phase zero, then it is slow that down. So you can see phase zero is slow down in both class 1A and class 1C antiarrhythmics. When if you are remembering your Vaughan Williams classification that we'll discuss on another class, but basically there's a Vaughan Williams classification 1, 2, 3, 4. And one has 1A, 1B, and 1C. All of these are sodium channel blockers. But class 1A and 1C agents, they will slow down the phase zero of your depolarization. And that is basically what is going to lead to QRS prolongation. But One thing that I would like to emphasize in this particular side is that when it comes to class 1B agents, like your lidocaine, it does not slow down phase zero of your depolarization, and it might actually reduce the duration of your QRS complexes. So lidocaine, lidocaine can actually reduce the action potential duration. And when it comes to toxicity with sodium channel blockers, if you are having ventricular dysrhythmias and you want to give an antiarrhythmic agent, lidocaine is the antiarrhythmic of choice. Now, this is something that is extremely confusing, and it was very confusing for me also, because I used to think that okay, lidocaine is coming in the same class as these other agents like class 1A, class 1C agents. But so why are we giving it? So, but the actual physiological mechanism behind this is that it is not actually prolonging the action potential duration. So you have to keep this in mind, because this is a slightly confusing area. Coming to the physiological effects of tricyclic and depressant, it has a multiple mechanisms of action. Most important for the emergency physician and most dangerous is the sodium channel blockade, which happens in overdose leading to QRS prolongation. It can also have some anticholinergic activity, so it can lead to an anticholinergic toxidrome. So what does an anticholinergic toxidrome present like? So we discussed this in the last classes as well. Basically, any part of the body that makes secretions, it will be solved. So it will reduce the secretion all over the body. It will increase the temperature, and it will cause dryness all over the place. So dry mouth, dry armpit, hyperthermia, rhabdomyolysis, all of these things can happen. Patient will become altered, can lead to seizures and all, and can also cause other things like urinary retention, ileus. This is basically what an anticholinergic toxidrome entails, and can have mydriasis leading to visual disability. How do you differentiate this from sympathomimetic toxicity? One, sympathomimetic toxicity will have increased sweating. Here, sweating and all is decreased. Second is that even though both of them will have dilated pupils, here it will not be reactive to light, but in sympathomimetic toxicity, will be reactive. So that is how we differentiate the two. Now that is one thing. Next, it actually has some alpha-1 blocking properties, which will lead to vasodilatation. Vasodilatation will lead to shock. So that is another. So that is double trouble here. So sodium channel blockade can lead to cardiac toxicity. That will lead to hypotension. Alpha-1 blockade, that will lead to vasodilatation. That will also lead to hypotension. So central antihistamine activity is also there. That will lead to somnolence. This is very common. So if anytime you give a patient TCA, even in normal doses, that it can make the patient sleepy. So that is one of the reasons why generally people don't like it, especially if you have a young patient who's going to college and all. They don't like TCS because it will make them drowsy and all. Central GABA A receptor blockade. This can lead to seizures, and its name is tricyclic antidepressant. So it will inhibit the presynaptic reuptake of dopamine, norepinephrine, and serotonin. And this is what actually produces the antidepressant effect. So basically, tricyclic has multiple mechanisms of action. So it can have, in overdoses, it can have multiple clinical features as well. So pharmacokinetics, number one, it is lipophilic. So, and it will cross the blood-brain barrier. So when you read things like lipophilic, then there comes the theory of whether a lipid emulsion will be useful or not for this thing. The evidence base for intralipid in TCA toxicity is very, very less, and it's basically animal study level evidence. So it's not that great. So it, uh, it will cross the blood-brain barrier. Peak manifestation of general comes within 2 to 6 hours. And it has high protein binding and high volume of distribution. So when you hear these kind of words, what should it strike to your mind? This is not a very good drug for dialysis. So if you remember the properties of dialysis that we of a dialysable drug that we discussed in the previous slide, everything was low volume of distribution, low protein binding, low molecular weight. The only thing that was increased was actually water solubility. Everything else was supposed to be low. And elimination is by hepatic oxidation. Now, there is a huge list of medication that can also cause sodium channel blockade. So they can have similar manifestation to your tricyclic antidepressant. So other antidepressant like bupropion, citalopram, fluoxetine, venlafaxine, all of these things can cause sodium channel blockade. As we discussed earlier, type 1A and type 1C antiarrhythmics will cause sodium channel blockade. Some kind of beta blockers like propranolol can do this, and some kind of antipsychotics like thyroidazine can do this. Antihistamines, very commonly used drugs, chlorpheniramine, diphenhydramine, these can cause sodium channel blockade. Anti-epileptics, remember carbamazepine. Carbamazepine is very notorious for causing the sodium channel blockade, and it can also cause some anticholinergic features as well. Anti-malarials like chloroquine can do this, and some miscellaneous like cocaine and tramadol can also cause sodium channel blockade. So all of these things can produce sodium channel blockade and can present with the cardiac manifestations that we are about to discuss in just a little bit. Generally, toxic levels is more than 10 milligram per kilogram in adults and more than 2.5 milligram per kilogram in peds. So the only tricyclic with antipsychotic effects is amoxapine. Why? Because it also blocks the postsynaptic dopamine receptors. So this is one of the drugs that can produce seizures despite having a normal QRS. Generally, the wider the QRS gets with the TCA toxicity, the more risk the patient will have of developing seizure. So once it goes beyond 100 milliseconds by the QRS complexes, then the risk of seizures will increase. But in this particular case, you will have a seizure even with a normal QRS complex. The most potent sodium channel blocker among the TCH is dacipramide, so it can cause severe cardiotoxicity. So what is the most common symptom that a patient will present when it's going to be autoterminal status? So what is important here? If the patient is having a GCS of less than 8, and this is a strong predictor of serious complications. So the lower the GCS is, the more likely that the patient is going to have serious complications like seizures and most common dysrhythmia is sinus tachycardia. So these patients will be tachycardia. That is what I want to emphasize here. So you can have mild to moderate toxicity and severe toxicity. In mild to moderate toxicity, you can have CNS manifestation like altered sensorium, slurred speech, ataxia. Then you have all your anticholinergic features like dry mouth, axilla, tachycardia. Sinus tachycardia is basically due to anti-muscarinic effect, basically. Then you have a urinary retention, ileus, or anticholinergic manifestation, and can also have things like myoclonus and hyperreflexia as well. Secondary to those manifestations, you can have other complications like aspirate. Patient can aspirate, leading to aspiration pneumonia. Patient may develop pulmonary edema due to the cardiotoxicity. Hypoxia can lead to hypoxic encephalopathy. The anticholinergic toxicity, as mentioned, can lead to hyperthermia and rhabdomyolysis. Serious toxicity is basically when you have severe manifestation within 6 hours, like coma, conduction abnormalities, ventricular dysrhythmias, hypotension, seizures, and respiratory depression. So, having said all of that, how do you actually diagnose TCS toxicity? First and foremost, if you have a history of exposure to tricyclic antidepressants, then obviously the diagnosis becomes a lot easier. The symptoms are vague. Let's be honest, just based on things like altered sensorium, tachycardia, and all. It's difficult to start calling this sodium channel blockade or TCA toxicity. Urine toxicology, we have mentioned in the previous class also, urine toxicology is basically useless most of the time. So in this particular case, you'll have a lot and lot of false positive, especially with carbamazepine, cetirizine, quetiapine, lots of things can cause false positive with your urine toxicology for TCA. So what is the investigation of choice most of the time? That is going to be your ECG. So it is the only test that is capable of suggesting sodium channel blockade rapidly in a patient with unreliable or unobtainable history. And if you have a broad QRS complex, we'll discuss in a little bit. But if those QRS widening features resolve after a couple of ampules of bicarbonate, that again suggests the diagnosis of sodium channel blockade. And in mild to moderate toxicity, you can monitor for early development of sodium channel toxicity by doing regular ECG. So this is the role of ECG in sodium channel toxicity. So this is an example of sodium channel toxicity ECG. I've taken this from the Life in the Past Lane website. So one thing that you have to understand when you're discussing ECG findings in sodium channel toxicity is that the right ventricle is slightly more prone towards the sodium channel blockade compared to your left ventricle. So the right ventricle will get depolarized slower compared to your left ventricle. So what will that resemble? That will generally resemble a right bundle branch block type pattern. That is one thing. Secondly, the important finding that you look for is there will be QRS widening. As I mentioned, QRS will be widening. What you generally mean by QRS widening on the ECG, when the QRS complexes are more than 3 small squares wide. That is what you generally mean by QRS widening. And in the lead AVR, you will get a terminal R dash wave. So you see the terminal wave here on lead AVR. And if that terminal R dash wave sorry, it's more than 3 millimeters tall, that is favoring the diagnosis of TCA toxicity. So this is some of the features that will help you diagnose this TCA toxicity, and keep this in mind whenever you're suspecting a toxicological overdose and you're not sure what it is. ECG can give you a big clue if it really reveals these kind of findings. So you are not always going to be sure whether this is actually going to be sodium channel blockade or not. If based on a ECG a lot of the time. So you will give some bicarb, and if you see the QRS narrowing like this after you give bicarb, that favors the diagnosis of TCA toxicity. So I hope that is clear. So this is a very important clinical point that you should take from this particular lecture. So these are the important ECG findings that you have to remember both in real life as well as for exams. So QRS widening more than 100 millisecond, terminal RV more than 3 millimeter tall in AVR, or an R by S ratio more than 0.7 in lead AVR. So basically big R wave compared to the S wave. The R wave is bigger than the S wave in AVR. And standard tachycardia due to anti-muscarinic effects.
Sir, actually, sorry to interrupt, but I just have a doubt here. Why do we call it as a terminal R wave? Why can't we just call it as a normal R wave? Like,
oh, sorry. So
it
should be called R dash wave actually. So it's like this thing.
You mean the second positive?
Second
positive wave is what you're talking about. But here, are we able to appreciate a second positive R wave? I mean, are we able to appreciate a first R wave is
this thing should there a lot of times there might be a very small R wave beyond that. Sometimes it might not be there. So that is why it's basically what they mean is that this terminal wave only. Whether it is a R wave, you want to call it R wave or R dash wave, this terminal thing is what they are basically meaning by more than 3 millimeters.
Right. So if it is an RS wave, you wouldn't actually go ahead and call it. That is the endpoint, right?
RS mean they have given that ratio thing, okay. More than 0.7. So another thing that another clue is that you might have this thing along with this thing, the terminal the R dash or R wave more than 3 millimeters. You can also have a prominent S wave in lead 1. So that is another clue to the diagnosis of TCA toxicity. All of this happened due to delayed repolarization of the right ventricle. So what are the differential diagnoses of these kind of ECG findings? So let's be clear that these findings, even though in exams, everybody will jump to the diagnosis of TCA toxicity, there is a differential, and oftentimes it might not be clear cut. So those differentials are, one is hyperkalemia, second is Brugada syndrome. So hyperkalemia, especially when you have severe TCA toxicity, very severe TCA toxicity, you can have a very, very, very wide QRS complex. So when you have QRS complexes, 5 small squares wide, more than 5 small squares wide, only a handful of conditions can actually cause that. One of them is hyperkalemia. That is the number one thing that you would like to think of. Little bit lower down on the differential, the number 1, number 2, and number 3 diagnosis is always going to be hyperkalemia when you see this kind of thing. But lower down on the differential is going to be severe sodium channel blocker toxicity. That can also present like this. That is why if you are not sure, you can give both hyperkalemia management and bicarbonate, because the basic management for what this thing is bicarbonate only. And even if your diagnosis is not accurate, bicarbonate is not going to harm anybody, and usually calcium gluconate is not going to harm anybody in the acute setting. And if you don't do anything quickly for this kind of ECG, the patient will go into cardiac arrest usually very, very quickly. And this thing can obviously look like VT only, but in general, VT will not have a QRS complex more than 5 small squares wide. So if you have QRS complexes more than 5 small squares wide, you should start thinking of the mimics of VT, like hyperkalemia, like sodium channel blockade, like severe metabolic acidosis. Another thing is Brugada pattern. There is something that you have to understand with this, is that there is something called a Brugada pattern, there is something called a Brugada syndrome, though both of these things are not the same. So Brugada pattern can be caused by multiple things. One of the things that can cause a Brugada pattern is the sodium channel blockade, as this particular case was due to propofenone overdose. So what does a Brugada pattern basically mean? In V1 and V2, it will basically look like your RBBB pattern. Basically, it will going into the RBBB RSR dash pattern, but it will go down into a inverted T wave. The XG segment will start sloping down, followed by an inverted T wave. That is there are specific ECG diagnostic criteria and all that I'm not going into. This is the basic fund of what actually a Brugada pattern looks like. Usually we will find it in V1 and V2. There is a type 1 pattern, type 2 pattern, type 3 pattern, etc. This is the type 1 pattern. That is the most specific for Brugada, most significant Brugada pattern actually. Brugada syndrome is different. Brugada syndrome, you can only diagnose if there is a matching clinical picture along with that, whether there is significant family history of some ventricular arrhythmia or sudden cardiac arrest or non-vagal syncope, all of those features. So all of those features combined with the ECG pattern that will lead to the diagnosis of Brugada syndrome. But if you only have the ECG finding, that is the diagnosis of Brugada pattern, which can be caused by multiple things, not just Brugada syndrome. It can be seen with things like hyperkalemia. It can be seen with some myocardial ischemia sometimes. Sometimes with patients with the Brugada syndrome, they will manifest the ECG findings and the patient develop fever. So those are some of the things that you should keep in mind with Brugada pattern. It is not at all specific for TCA sodium channel blockade, even though it can cause it, and you can diagnose cardiac toxicity due to sodium channel blockade in the right clinical context if you see the ECG pattern. But as such, it is not in the ECG this list that they give. The Brugada pattern is not actually in this list of typical ECG findings, but it can be there sometimes. I hope I didn't confuse people. Coming to QRS widening in TCA toxicity, as I mentioned earlier, there is some prognostic significance to this also. More than 100 milliseconds increases risk of seizures. More than 160 milliseconds increases risk of ventricular dysrhythmias. So that was basically about diagnosis. What about management? Management is always going to be ABCDE approach. As I said in the last class, most of toxicology is going to be supportive care only, and patients are going to survive if you give proper supportive care. Antidotes are you cannot, even in TCA toxicity, sodium bicarbonate is not a classical antidote per se, but it is good. It has some certain indication. So it's I'm not sure if it fits in the perfect antidote definition, but more without the proper supportive care, the patients are not going to have good outcome. So when you go for the APGCD approach, the initial airway, what are the indication for intubation? Low GCS, generally we take GCS of less than or equal to 8. Some people may take that as controversial, but in this particular case, that is probably appropriate. Seizures, probably you'll end up having to intubate the patient, especially the patient goes into status. If the patient is hyperventilation, patient is going into respiratory acidosis. That will make all of these things work. If a patient is going to go into respiratory acidosis, it will make the risk of cardiotoxicity and neurotoxicity a lot worse. So you have to intubate that kind of patient if the patient is going into respiratory acidosis. So what are the things that you should look for while you are intubating? Before intubation, try to give bicarbonate if possible, not always, and allow if the patient is able to breathe properly, allow them to blow off that extra PCO2 as well before you actually tube the patient. Try to improve the hemodynamics as far as possible. This is a general principle in any kind of ED intubation. Always resuscitation before you intubate. Easiest thing is to put the tube through the vocal cords, but trying to do that without actually killing the patient, that is the actual skill of the physician. During intubation, you have to try to avoid hyperventilation as far as possible. So you can consider apneic ventilation with the NIV. Recently, there is a pre-oxy trial as well, which showed that we probably should be doing that for most of our patients actually. But sometimes the patient is having a huge aspiration risk. Maybe that might not be possible. But if it is possible, please do consider that, because you don't want to have hypoventilation in these kind of patients. Post intubation, increase respiratory rate and try to go target mild hyperventilation, so a low PCO2, somewhat lower than we usually target. That is something that we have to look for in these kinds of patients, because in a lot of our patients, you'll be trying to target a low normal pH. So often might not be possible to actually normalize the pH in a lot of patients, but we generally at least try to target a low normal pH. This is one of the conditions where we are trying to target a high normal pH, or even a moderately high pH. So we have to really try for hyperventilation in these kinds of patients. And for sedation, you give a sedative with some kind of anti-epileptic property. If the patient is hemodynamically stable, you can consider propofol. If the patient is hemodynamically unstable, you can consider some kind of benzodiazepine infusion. GI decontamination, as I said in the last lecture, very difficult in tertiary care center to get patients who in the time window where activated charcoal will actually be useful, but it can be considered if the patient is actually presenting early and the patient is having a patent airway. Multi-dose activated charcoal and whole bowel irrigation is not indicated because things like ileus can happen. So those things are not to be done. Hypotension can be multifactorial, as I said, cardiotoxicity as well as alpha blockade leading to peripheral vasodilatation. So usually this thing is not going to resolve with fluids alone. You can give fluids, but you should generally have a low threshold to start vasopressor, because this is not going to be a purely fluid responsive thing most of the time. And the choice of your vasopressor, you can it basically depends on what the heart rate is. If the heart rate is normalish, you will go for a usual approach of NORAD. If the patient is bradycardic, you can go with ADR, and if it is not responding to either of those, you can start the patient on vasopressor. If the patient is having tachycardia, don't try to reduce the tachycardia with the beta blockers. So that is not to be done. So, what are the indications for bicarbonate therapy? So this is we reflexively, when do we give bicarb? We will give bicarb for acidosis, that is, or NAGMA. So those are the common indication that we have for a lot of patients in our ED, but the indications are slightly different in this particular case. With the patients that having ventricular dysrhythmias, you have to give bicarb. Patient having seizures, you have to give bicarb. Hypotension not resolving with uh, your fluids and all, you have to give bicarb. QRS more than 100 milliseconds, you have to give bicarb, unless the patient's baseline was also already a prolonged QRS. So these are the indication for bicarbonate therapy, which is somewhat different to what we are usually familiar with in other patients. So the dosing, however, is similar to what we usually do. Usually give a 100 millicurie bolus, and after that, you will generally see the narrowing of the QRS complexes, and you will repeat as needed to decrease QRS interval. If the QRS interval doesn't actually change after 200 millicuries of bicarbonate, then you should start questioning whether the diagnosis is actually correct. Then this is actually showing toxicity problem. But the caveat there is that if the patient is actually presenting with a huge overdose of that particular medication, then sometimes you might have to give higher boluses to actually get the desired effect. Isotonic bicarb is basically what we are usually giving in our ED. So the concentration is 150 milligrams in 1 liter. If you don't have 1 liter bags, you can give half of that, 75 milligrams in 500 ml. And you can give it around 2 to 3 ml per kg per hour, or around 150 to 250 ml per hour. And what are the therapeutic goals with bicarbonate therapy? So the goal is to narrow the QRS to less than 100 milliseconds. Keep the pH on the higher side, 7.5 to 5 to 7.55, and try to avoid the usual complications with giving lots and lots of bicarb, like hypokalemia and all, and hypernatremia. So you're going to be monitoring the electrolytes and the blood gas every 2 to 4 hours or so. What if the patient is coming with VT? There are a few things that you have to know. One thing is that in general, as we do for all VT, if the patient is unstable, you have to shock the patient. What do you mean by unstable? Hypotension, altered sensorium, signs of shock, acute heart failure. Ischemic chest pain is not really applicable here, but those are the ACLS indications of instability when it comes to arrhythmias. So if any of those are there, then you go for electricity. And as I said, ventricular dysrhythmias means you have to give bicarbonate. And if you feel that antiarrhythmic is needed, then then the antiarrhythmic of choice here is going to be lidocaine. So it's going to be 1.5 mg per kg bolus, followed by 1 to 4 mg per minute infusion. And if it's resistant to bicarb, then you can consider adding magnesium. Lipid emulsion therapy, as I said, the evidence is basically animal level studies, but you can consider it if nothing else is working. A few caveats that you have to remember is, one thing is amiodarone is not indicated here, and it may worsen things because it will increase QTC, and it can make things worse, lead to more ventricular arrhythmias. And patients presenting with a white complex tachycardia, it might actually be sinus tachycardia with the delayed conduction. So it might not actually be VT, even though it's looking like VT. So we saw an ECG earlier. So this thing you might struggle to see a P wave sometimes because they are hidden on top of the T waves. So sometimes you might be confused into thinking this is VT, but if you one thing that will help there is if you give some bicarb, it will narrow. So that is how you figure out that was not actually VT, that is actually sinus tachycardia, but with a delayed conduction. So what about seizures? Seizures, there are other things that you have to be aware of here that is slightly different from our usual algorithm. The initial management is the same, you give benzodiazepines and all. Seizures, again, it is another indication for bicarbonate therapy. Maintenance anti-epileptic, when do you give? You don't, does the patient need to have long-term anti-epileptic? No, because it is usually a reversible cause of seizure. Okay. But if the patient had status or the patient is having recurrent seizure, you generally would like a maintenance anti-epileptic, and generally you can give something like levetiracetam in that particular scenario. But one thing you're not supposed to be giving is phenytoin, because phenytoin can also cause sodium channel blockade and make things worse. So no phenytoin in this in this scenario. So to summarize, so approach to any tox patient. So don't blindly follow the usual algorithms for when to give bicarbonate or when giving things like amiodarone or phenytoin, because things are a little bit different when it comes to your toxicological patient. And or be very familiar with your ECG findings in TCA toxicity, and ECG is going to be the most useful test that you will have at your disposal. And remember that lidocaine is not like your other class 1 agents. It is not actually going to slow down this phase zero of the cardiac action potential, and it will actually shorten the cardiac action potential, and it will actually be useful in some kind of arrhythmias due to sodium channel toxicity. So even though that might sound confusing if you have a superficial idea of how these agents work. So that is basically about today's lecture. And if anybody has any doubts, you guys are free to ask anything right now.